Hello, everyone. Welcome to Bright Spots in Healthcare, produced by Shared Purpose Connect. We bring leaders together to not only inform you, but also unearth bright spots, successes at health plans, hospitals, and other healthcare organizations around our nation. Our goal is to identify as many bright spots as possible so that you can determine if the ideas shared during this episode can be applied at your organization. We believe this approach of finding a bright spot and cloning it is the most effective strategy to improve healthcare in our lifetime. If you are new to the show or have not yet subscribed to the podcast Bright Spots in Healthcare, stop what you're doing right now, especially if you're watching on Zoom. Go over to your tablet or iPhone or Android, go to your favorite app that you listen to podcasts on, type in Bright Spots in Healthcare, and please subscribe. And if you're so inclined, leave us a comment like this one from Dr. Kin Jaden, who said, "Hey, great guests that help promote problem solving in public health." So just a quick little comment like that helps more and more healthcare leaders find the show and tap into all the great insights that our guests share and hopefully inspire them to bring those great ideas to their organization, making healthcare better for all of us. We've been doing the show for a long time, presently averaging 4.8 on Apple. So the guests are good. The ideas are good. We encourage you to subscribe. Our topic today, unveiling the transformative power of consumer marketing and health equity to drive more customers into your healthcare system. We have an incredible roundtable of guests that we have put together for you today by our esteemed producer, Sherry Keels, whose birthday it is today. So everyone wish Sherry happy birthday. But to save time, we're not going to sing happy birthday, and nor are we going to formally introduce each one of our guests. We're going to bypass those introductions. Sherry's going to post a link to their full bios in the show description on your podcast app, as well if you're watching right now live on Zoom, into the chat so you can get a sense of the great expertise you are about to benefit from this afternoon. Our sponsor today is Purple Lab. Super excited to have them on board with Bright Spots. They are a health tech company that is putting valuable healthcare insights together to enable all of us in the industry to drive better outcomes through access to real world data. I'm going to tell you a lot more about them later on in the show, but if you want to check them out, simply go to purplelab.com. All right, let's get started. We have organized today's discussion into three themes: consumer centricity and the patient journey, personalized data-driven marketing, and health equity. We're going to kind of toggle through these themes throughout the discussion. I'm going to start with theme one right now and bring in Dr. Abraham Barkuda. He is the System Chief and Regional Chief Medical Officer and Chief Quality Officer at Baystate Health in sunny Springfield, Massachusetts. So, Abraham, thank you for being here. Understanding how individuals enter into the healthcare system at different stages in their life, at different stages within their journey. How does Baystate think about this complexity to consumer centricity and make it an advantage for your health system?
Perfect. Eric, thank you very much for having me. This is a pleasure and privilege. So maybe just to set the table for my esteemed colleague and build on what you mentioned, Eric, the consumer here is the patient, right? And this is the patient-centric approach that I hope we all learned from in healthcare. I'm going to explain two concepts here: the episodes of care in which the patient either at home does not need us. That's fantastic. One episode would be the clinic or the outpatient, and this is the bigger cycle of any patient's life, the access to care through the clinics, through the telemedicine. The second part, which is the more into the resources, the inpatient aspect of the care, the hospitalization part, the surgery part, where the patient, she or he or them, will require more resources. I'm going to bring it back home to Baystate and maybe put the model that we center our access around, the OATH model, OATH, the orchestrated access to health. It's a model developed by our chief physician executive, Dr. Andrew Arnstein. And the goal here is to put innovation approach around how that continuous of care would look like in healthcare and the interaction of the consumer, the patient, throughout their phases of their life. The model, which is published in New England Journal of Medicine, Catalyst Innovation, it brings the models of the healthcare delivery and the value of how we will reach collectively the meaningful outcomes. And most importantly here, with the lowest cost. So this is the value-based care where the outcomes divided by the cost would lead us to deliver care in sustainable fashion. The model also would address in the framework what we come across challenges in our practices. And I do practice in the inpatient settings where we know the access to care could be simple symptoms to the high touchdown, which is the emergency care and the hospitalizations. The goal here is to bring the patient, the data, the how we can deliver the health with its tactics, and how that decision support around bring it together and put the social determinant of health and who needed to have a better access into the oath model. A lot we need to innovate. We need to rethink and reimagine how healthcare post-COVID should be done. We need to think about the cost and that access, that capturing through access would matter the most for the millions of Americans that accessing healthcare daily. And we need to do better to give that access to our foundation at large.
So, and we'll get into this a little bit more later on, but it sounds like at the end of the day, the program is based upon access points at different places within your healthcare ecosystem, within your market, and allowing easier access and wherever someone is in their journey. So that's the premise behind the whole program. And we'll get into a little bit more how it works later on. Did I summarize that okay? Did I miss something?
You're right on. You're right on. So they're the patient. They're the episodes of how the patient would enter our healthcare, and how you can match the resources and the data for better access throughout that journey. Your summarization is right on, and this is the innovative part that we're reframing how the access to health should look like, and could be the care, but could be beyond that through the model of health.
Yeah, I'm excited to hear more about that. Incidentally, folks, if you're watching live, you can help me co-moderate by throwing in questions into the Q&A module, and we'll keep an eye on those. I will give a quick disclaimer. Knowing what we've planned for you today, we are really tight on time. So I'll do the best I can to integrate your questions into the flow of today's discussion. I want to bring in Timothy Brown. He's the Chief Communications and Marketing Officer down the road from Abraham in Stony Brook, at Stony Brook Medicine on Long Island. Tim, when we think about meeting the consumer where they are on their journey, can you provide like a real life example of a program you guys on the island have put together so that you can meet a patient where they are to not only provide better healthcare to the entire community as a whole, but also make sure that your business is healthy and growing?
Yeah, Eric, first of all, thanks for having me on. This is a great panel and just a great bunch of experts. So I'm humbled to be included. Stony Brook is an interesting institution in a very interesting geographic location. You know, we are on Long Island. We're in primarily Suffolk County. So that's the eastern 2/3 of Long Island. And Stony Brook is an academic medical center. But not only is it a real strong AMC, we have a bunch of ambulatory locations spread across the island, about 200 plus. And we have a couple of hospitals out on the east end of the island too, which is, it's a fascinating patient population. We have some of the most wealthy people in the world within our area. Then we also have some of the poorest people in the country, also in the same area. One thing that a lot of people don't realize about Long Island, home and still continues to be home to a lot of Native Americans, and oftentimes these are folks that fall through the cracks in a lot of different ways, but particularly in when it comes to healthcare. We're involved with the Shinnecock Nation, for example. This is one of the areas that really shows kind of the dichotomy that we face. We have a hospital in Southampton. You've all heard of the Hamptons, and Southampton is, I believe I think the zip code is in the top 3 in the United States as far as cost per home. But the Shinnecock tribe also has land there too, which is where the Shinnecock Nation, in part where the folks live, and we have a clinic there, a dental clinic and a medical clinic. So it just really shows kind of the differences in the populations that we serve. But one of the things that Stony Brook has done, and I support this with all my heart, they've really pledged to take care of people that maybe are a little bit less fortunate. One of those things, one of those areas is Stony Brook Home, and that stands for Health Outreach and Medical Education. I better get that right. And this is a fantastic program that was started by medical students, I think back in the mid 2000s, 2005, 2006, somewhere around in that area. Group of medical students got together and decided they wanted to do more for the community and really serve the underserved population. And so they put together a plan. They started working with faculty on that plan as well, but it is student-led. And they put this plan to really do medical outreach to people that were uninsured or underinsured. And it's pro bono, it's free. And it really does serve a population that oftentimes otherwise would fall through the cracks. So that's one example. There are many more, but it's pretty gratifying to see these students, and the students aren't forced to do this. This is a voluntary thing. So even to this day, our med students that want to be part of it can be part of it. They're supervised, obviously, but they do some wonderful work for folks that are truly underserved, and the cost is then absorbed by the institution.
I love, by the way, that like students came up with a new idea and now you've incorporated to sort of the organization's ecosystem. How how is it funded, and two, any results that you could share, at least at a high level, whether it's around utilization engagement or something else that you may have?
So the funding is 100% internal through the organization. So it's absorbed. It's basically our we write that off as charity care. And it's been a very successful program. It's shown growth over, I can't say every year, but most of the years that it's been in existence. COVID was a challenging time, obviously, for everyone and for the clinic, but I think it also showed the value of the clinic because there was a significant increase in traffic for folks that needed help, needed testing, and that sort of thing. So it's difficult to show business results on something like this or an ROI because there isn't one, but it is the right thing to do. And for an institution of our size, it's doable, and it's certainly has a positive impact on the community.
Like that. I'm gonna switch us over to data-driven and personalized marketing, theme number 2, as I labeled it at the onset of today's episode. I'm going to bring in Ted Sweetster, who's the head of strategy at Purple Lab. Ted, how can hospitals today take a more sophisticated, like Madison Avenue approach to connecting with potential new customers, aka new patients?
Yeah, it's a great question, and it's one we think about a lot today on the ad side of Purple Lab. We were founded initially to support life sciences in a broad range of functions. But as we matured in the space, we found that there were a lot of areas where people were missing the dots between a lot of work that's occurred on the health side of things in population health in terms of developing a clear persona of who needs to fit into what lines of therapy or treatment, and the substantial advances that had taken place in digital marketing in terms of being able to accurately understand how to meet the patient as a consumer at those points in the digital media ecosystem where they're actually spending their time. So that is, we can understand and characterize the patient by their social determinants of health. We've been able to do that for years, right? But, the next step process is when you go to develop a strategy for an objective, like say new patient acquisition, for a specific facility in a given geographic area. How do you translate that into, a set of clear tactics that are going to maximally engage that population that you need to work with, and understand the value of those different tactics so that you can shift, learn what the ROI is, and sort of focus your marketing efforts on those channels that really drive the greatest success in terms of, not just making awareness. Brand is great, but that brand awareness leading to a patient journey of coverage, maintaining a patient in just a standard of care for, clinical annual checkups and stuff like that, or moving them into more specialty treatment associated with that organization. So case study, I think that you wanted me to speak to, I can sort of talk through that.
I'd love to hear an example for sure.
Yeah, so one example I can share, blinded in this case, is there's a teaching hospital that uses our data in the Southeast, which was concentrated in a single metropolitan area, but had a lot of ambulatory centers, as most systems now do, all throughout a broader range of the network. So their goal was, they had been in practice 50, 70 years, something like that. But they needed to re-engage with the broader population to develop more brand recognition for the uniqueness of what they as an academic medical center were able to provide to patients, and then use that awareness to drive new patient acquisition, and also hopefully leverage marketing as one of the functions to prevent leakage out of the network of care that they'd been developing. So to do that, they looked at one of the, departments that they were operating in for treatment of chronic conditions, and started to leverage our, social determinants of health data to build those personas. So we end up with one persona I think we talked about previously is, let's call someone, like Joe. Joe is 57 years old on average, male, mid to upper class in terms of income, with a college education, higher propensity to be white, and over-indexing for obesity as sort of background indicators. That's great. That can give us a lot of information to build the creative and the content story that we want to use to engage that population. But what we really want to do, that's sort of the modern add-on to that, is to understand, hey, now that we have this persona, let's look at all of the different channels that we have for engagement, which are a range of different digital channels, as well as your classic digital out of home is what they call billboards these days and stuff like that. And look at how frequently, we're able to reach that persona using this range of different tactics. So we start with a question of addressability. Now that I know who I want to reach, how can I get to them? And so, doing that mapping of the, social determinants that are classified by the clinical indicators we can observe, we can find information like, we can reach 36% of the Joes that we see in this metropolitan area by doing targeted advertising on, television programs at a certain day part and things like that. First step. The second step, where we're really getting modern, is how can we start to move past just knowing where we can address them and understand how that drives towards the end goal, which is new patient acquisition. And that's where we've been sort of innovating is, we can take this massive data, and I gave Joe as an example, but in the actual case in question, there are 128 different tactics that are being tested initially to try and figure out how best to reach this market. By converting that back to understand patient growth or patient acquisition, we can winnow that down to, 4 of the highest performing tactics and really focus our efforts on those to drive the greatest impact in terms of growing the footprint of this institution in that geography.
So that's just sort of non-healthcare stuff you just threw out there. So I want to try to summarize what I just heard so everyone can capture this, because I think this is super important, because this is how the Cokes and the Teslas and the Apples do what they do. So This is gold. So you mentioned this academic hospital, tertiary hospital.
Yeah.
We brought up Joe. You identified how you were most likely to reach, based upon all kinds of data, where you're most likely to reach Joe. But then it's not just where to reach him, but it's also where you're going to have to go to actually drive a behavior change or an action. And so you take all the data now, bubbling it up from Joe and looking at that patient segment specifically that maybe Joe fits into, and you listed all the different kind of persona characteristics. You need to understand the highest performing tactics and then focus investing in those to drive that change. Is that a quick Cliff Notes version of what you just laid out for us?
Yes. And in short, like in the healthcare space, we talk about the patient journey as being, this set of discrete stages for treatment of an episode, whether that's chronic or acute, and the different things that need to happen and the touch points with the patient throughout that journey. In the ad tech or the marketing space, we talk about the marketing funnel, which is, we could say roughly analogous, right? But what we really need to do is connect those two things together to actually understand the impact of ROI for hospital systems and healthcare general. So that, in marketing speak, we say the top of the funnel is awareness. So do they know that you exist as a hospital? And then there's a consideration and evaluation stage and stuff like that. Our thought is that, by connecting these dots together, we can actually get a much better understanding of exactly that, how these digital things, which feel fairly ineffable in terms of strategy composition, can actually translate meaningful outcomes, and from there to real ROI statement for investments and driving awareness.
Yeah, I like that a lot. I want to move over and switch over now to our third theme, which is equitable access, and just looking at health equity and SDOH. One of the things, though, I do for each episode when I'm doing my research is thinking about what content we could provide our live listeners that are relevant to the topic we're talking about. And those of you who are regulars know we try to do this. In my research for this show, I stumbled upon an article that was written by Dr. Russell Robbins. He's the CMIO, Chief Medical Informatics Officer at Purple Lab. And it was a case study, different from what you just heard presented by Ted, around how they leveraged SDOH to address some of the inequities and disparities in medication prescribing patterns for folks with a chronic illness. In this case, it was psoriasis. But I think being able to get a gist of how they take data and incorporate it, and it's a non-promotional piece for the most part, or I wouldn't be offering it to you guys, but I have the piece here. If you guys want me to send it to you as a follow-up, I'll personally email it to you. It is entitled How SDOH Impacts Access to Therapies. Again, Dr. Russell Robbins was the author of it. And it peels back how they take SDOH information and applies it into understanding who's most likely and least likely to get their prescriptions filled around medication adherence. All right. I want to converge now patient centricity and SDOH and how this creates a system for equitable access to quality healthcare. I'm going to bring in Molly Luton. She's the Chief Marketing and Communications Officer at Ballad Health. They are a merger of two competitive health systems. Back in 2018, they merged. They covered the Southern Appalachia over two states, Tennessee and Virginia, just to get your heads there. They cover, their population is about 1.2 million people they serve, most of which sit in rural communities. And when I mean rural, for context, their largest city within their market has about 80,000 people. So with that as the background, Molly, how is Ballad thinking about the social challenges facing your members or your consumers and using that as a roadmap to reach out to potential patients and provide them with foundational ingredients for better health? Not necessarily the healthcare services, but some of the things that are so important to enabling better health.
Sure, Eric, thanks so much for having me. It's my pleasure to be here, certainly amongst this group. So when Ballad Health came together in 2018, we really had a unique problem at hand. You mentioned the merger. We actually have the largest certificate of public advantage, COPA, in the country. We had two health systems that came together, a Coke and a Pepsi, in market, in inpatient hospitals that were highly competitive. It was a matter of who was going to be on sale first. And we had the same unique patient population. Tim, you mentioned your diverse audience and the folks that you see. we're the latter part of that audience that you explained. Really, we're the folks that have incredible access challenges, have transportation challenges, certainly have literacy and educational barriers. And so for us, we're serving a population, you mentioned, Eric, 1.2 million people, but for context, the geography is the size of the state of New Jersey. It takes almost a half a day or more to drive from one side of our region to the other. And so with that, we have extreme black holes of Wi-Fi and broadband. It's often said that about 65% of households in our area have broadband access, only 65%, which is unreal. I would imagine, Tim, at least in your area, you guys probably have 1 or 2% that don't have access to broadband. So for us, trying to find a way to use the synergies of the merger, we promised the communities that we serve with our approved merger, we would save about $308 million over the course of 10 years. And with that promise, we had to figure out really creative ways to give back to the community, to get them into healthcare, to get them to engage. Obviously, we weren't trying to get everyone into a hospital per se, but re-engage and engage that primary care process. If that meant establishing mobile units and getting more aggressive in our on the road approach, we would do that. One of the things we did that I'd like to offer you today is we found that in Appalachia, there's obviously, like many of you, there's obviously opportunity for employment, for improved employment, and unemployment rates can be relatively high in some of these pockets as coal mines and other environment industries have changed over the last decade or so. So public libraries were really used in our area as a place where a lot of people would come and apply for jobs. And so we decided, hey, how can we start to build the trust that people have in this community when they go to a library to apply for a job? How can we use that same concept of trust and build that into their healthcare experience? We've done a lot of study on the patient journey and really trying to understand through patient journey mapping what the patient's experiences are, what are their needs, what are they hoping for, what do they expect from us? And really the top piece of all that is trust. So if we can offer something as simple as Wi-Fi access to them, then we might be able to build some trust with them. So how we've done that is by really pushing out our fleet of mobile health coaches, where we have primary care and women's health and mammography. Obviously, a lot of folks have that offering. And if people can come and get the idea that, hey, I'm going to get free access to Wi-Fi so I can apply for those jobs, but I'm also going to maybe get that mammogram that I need, or I'm going to get that cervical exam that I need. So we can start to build that level of trust with these folks that will eventually, hopefully, end up in a more integrated, trust parameter for us and build that relationship that we need with the patient. So it all starts with Wi-Fi, funny enough.
I love that. Do you have any results? Like how many people engage in that? Do you have a way of tracking that?
We do. So the program has been engaged in our community for about 6 years, I'd say. We have at least 2 buses on the road every week, and we're seeing thousands of patients. Over the last couple of years, we've been averaging about a $10 million investment into this program. We work hand in hand with several community organizations and partnerships out there that help us kind of sponsor the buses, if you will, to get their audiences to attend our bus events. And so we're seeing about 60,000 people alone just this year. So it's really been a popular program for us.
So over 60,000 a quarter would be a safe assumption.
This year.
Yeah.
Mm-hmm.
Right. So 60
calendar year.
And we're well past.
That's right.
We're well
That's
past.
Right.
It's not
amazing.
Right. You're not giving me a 12-month running thing. You're giving me the last 4 months, correct?
That's right. Mm-hmm.
Wow.
Yeah, it's pretty amazing.
Well, when you take it, you're only covering 1.2 million people, and you've engaged 60,000 to this program. That's pretty.
Mm-hmm. Yeah.
Sticking with that theme, like how Tim, you mentioned Stony Brook's got this sort of dichotomy of patient populations. How are you thinking about equitable access, and how are you investing in programming that is improving access similar to or analogous to Ballad?
Yeah, that's I love, first of all, everything that Molly just said. That was really interesting, and health literacy in being entwined with all of that, I think is also just so critical. And so I want to talk about a little bit about we have just recently been certified by the Joint Commission as one of the it's a certification for healthcare equity. And I think we're one of the first 8 hospitals in the country to do that. So this is something that's been near and dear to the hearts of the people here at Stony Brook for a number of years to get to that area. And, it's playing off of what Molly just said. So it is so important that people know what they need to do to stay healthy. And I know that sounds kind of like a basic thing, but a lot of people don't understand that. And they have a lot of learning to do to get to that stage. And we had and again, this is I think an area where I'm just really proud of the effort that came through our program in public health. They established it's a program through our library system in Suffolk County, and it's called Healthy Libraries. And basically, what they've done is they've trained, I think, over 250 students now to be involved in this program. That just it stretches across Suffolk County, and it works with the library system in Suffolk County, or the libraries in Suffolk County. And we have virtual healthcare opportunities, in-person opportunities for people when they come to the library, because a lot of times, and it's like Molly said, you get people that they may not have Wi-Fi, they may not be able to afford it in their homes. So they'll come to the library to access that. And so that's part of the outreach. So they can come to the library. They get the benefit of obviously the various things they can get from the libraries, but when they come in, they may see a Stony Brook table that's there and a couple of people staffing it, loaning out blood pressure cuffs so they can take home and monitor their blood pressure or their loved one's blood pressure if they have hypertension or other issues. And I think, as we all know, it's important when you get to that stage where you're having some of these challenges, these healthcare challenges. You need to monitor and be aware before it becomes a bigger crisis. And so that's one of the programs. There are quite a few others that are involved with that certification. We do have a mobile dental clinic, mobile health clinics as well. And of course, I think I talked a little bit about the Shinnecock Nation and some of the work there. So these are the kind of things, as a marketer, we always look at how can we make the most money for the institution, because that's, we have to keep the wheels turning. But it's also how to promote things like this and the outreach, and make the public aware that this exists, that they can come to their library and they can get these services, because if they don't know about it, it doesn't do them any good, obviously. And so we try to tell the story both ways, and try to tell the story to all folks, to let them know what's out there and really educate them on the possibilities and the things that not only are available to them, but that they need to search out and they need to pay attention to.
So partnerships with the public libraries in Suffolk County, obviously there's free Wi-Fi through the library, but you have a table set up, you're handing out blood pressure cuffs as one mechanism of engagement. And I'm assuming you're capturing individualized information at that interaction, is my guess. Just handing them blindly. And then the awareness is the biggest challenge, like just marketing that program out and educating the market on the possibilities of coming to the library on certain dates and getting screened and getting equipment for free.
Well, and the key then too is also the care that goes beyond that. If they can't afford it, obviously that's a huge roadblock for people, and oftentimes people stop their care at that point. So then we have counselors that will work with them to transition them into a program that, like the home program, for example, that can continue that care, so that they can hopefully get the help they need or stay healthy. That also benefits the organization. I mean, I hate to be this way, but it also benefits the organization, because you have fewer ED visits, and that's obviously expensive when people use ED as their primary care physician. We don't want that. Obviously, it's there for a safety net if it has to be, but if we can keep people into a different mode of care, it's advantageous to the organization as well.
Have you been doing this long enough to have a tail to know exactly what percentage of ED visits maybe has been reduced, or not yet?
I'm sure we have, but off the top of my head, I don't have the number for you, Eric. For the ED visits, I'm sorry.
I'm going to stick with the theme of sort of reading in the library. Bring back Molly here. Tell me a little bit, Molly, in your market, how you're investing in children and education to better just reach families, similar to what Tim's doing.
Sure. So I think we should bring Scholastic on as a sponsor of this segment, perhaps. The book content is great. So we know there's obviously correlation between literacy levels, right, and the potential success of a high school graduate. be it someone that pursues college or some other professional program or education beyond that, or the job market. So in Southern Appalachia, again, we're in a really rural part of the country where access is an issue. Access to solid schools sometimes can be a challenge. Access to books in general can be an issue. I'm sure some people, or I hope anyway, some of you have heard of the Dolly Parton Imagination Library. If you don't know Dolly Parton, make sure you write her in on the presidential election this fall, right? She's someone worth looking into. But she started an amazing program years ago where she started giving books to every baby that was born originally in Tennessee. And I think that program has really launched nationwide. But every child in that program received a book until they got into kindergarten. And so we kind of took a page out of that book, if you will, and decided to think through how can we as a health system, while this is really outside of a scope of a health system in many cases, how can we help elevate the literacy levels of children in our area? We might not be able to directly impact the levels of tobacco use, for example, in adults as easily as we can give books to students and to kids. And so we've created a really solid access point. We're providing books, we're providing tutorials, tutoring sessions for kids. And we actually have volunteers who are going into the schools from Ballad Health volunteers, folks that we've been fielding to go in and read with kids all over our region. This program was running really solid throughout the first few years of the merger. And then once we ran into the pandemic, we had to pivot and think, how can we bring folks into schools to help with reading programs? And so now a lot of what we've been doing is providing those books, providing those tutoring sessions. And we're seeing, it's really incredible. We're seeing thousands of kids that now have access to books, have access to getting up to that third grade reading level by third grade, that we hope 5, 6, 7 years from now, after we've tested this program for 10 years, that we'll see a solid test of change of literacy elevation within our region.
Wow. What's that called? If someone was going to.
So the program is called Bear Buddies. And our CEO and his wife actually came up with the program, Alan Levine and Laura Levine, and she's a nurse, and he's someone who's always had a passion for education, has worked with the Barbara Bush Foundation, and has always been impassioned by reading and the idea of giving books to kids that need them most. And so it's amazing that they themselves go in and help with these tutoring sessions, and it's created a really neat culture for all of us to want to do the same thing.
Love it. I want to switch back to sort of our first theme around consumer centricity and bring back Dr. Abraham Barkuda, System Chief and Regional CMO CQO at Baystate. If you've forgotten, it's been a bit since you were talking last. I want to bring you back in, Abraham. Let's come back to the Oath program that you introduced to us and talk a little bit about how that program is orchestrating consumer engagement and consumer enablement, and maybe even get into some of the outcomes.
Perfect. So Eric, just maybe to bring what Molly was sharing and have also Tim and the positive experience on how we could reach out to the community and bring the TED of the world and the data and bring it all together. The model which Baystate is praising, the Oath model, where it's not about healthcare, it's about the health overall and how we can achieve that rather than the episodic intervention in the patient journey. And to maybe zoom out a little bit and think about our journey as patients eventually in the system and how we want to interact with that and get our engagement. And I want to bring the system redesign IDEO like concept. The significance really would come down to the social determinant of health and how that would be heavily factored of how we enter the health cycle and get access. What I want to share and keep it maybe in the midst of what we do is seeing the system from the patient lenses or through their lenses, from that consumer of care to consumer of, I want the health. I want a 360 of stop smoking, treat my chronic conditions, prevent my acute visit to the hospital, what Tim mentioned, and really bring the data in, is really that holistic approach, the integration of the oath model that we're using, and have really cohesive system. Now we could say AI, we could say many interventions, but it's going to come down on how the patient sees our system, and she or he will gauge with us, because we want them not to be one touch to the library. We want them to have a reading hour in our library, virtual library, Dolly Parton type of approach every day, right? And this is important. This is the consumerism, not to buy a phone, but to have that access ready to go to health all the time.
You mentioned two things I just want to get some follow up with you on. Cohesive system. How do you do that?
So this would be the maybe $4 trillion question that we're going to try to tackle. Our systems are fragmented. We speak different EHR languages. We speak Russian in Paris, and we want to bring all these services together. If I had to say what brings us together is the patient, right? And if our patient want to know us, they need to know that we're consistent behind them. What I wanted to bring to this, that we came a long way. So we have many policies brought healthcare to up to speed in terms of technology, data, access, integration, innovation, but we still have a long way to go.
Okay. And I like it, because my next question was going to be how the patient sees our system, but it sounds like the cohesive part of it and how the patient sees the system is sort of comes hand in hand. But I'm curious, is there any one thing that you're doing to enable that the patient is seeing your system differently, and almost, even though they may not know oath by name, they know what the organization stands for by way of the oath program?
Perfect. So as a part of also ACO managed care, the patient should know when you get an A1C part of your diabetes screening in the clinic outpatient, the system will help you to assign the appropriate doctor diabetes, for example, clinic to get you linked to that. So they will give you that access to care. They will give you the preventive services. Eric, I want to put it out there. We're still trying to figure out what the best system would look like, right? And there's so many examples of this in terms of screening, treatment, prevention, but we're still working on it. And serving population of about 1 million patients in Western Massachusetts for Baystate is a privilege and also a massive aim that we need to do better. So it's matching the patient with the right services. And number two, the patient has access to their records. This is, again, a new way of you're gauging the patient and their part of the care. This is the law of the land, where you need to have access to your records. You have the right to do that and be part of that care.
Great. So I think there's a great opportunity to segue back to sort of personalized, data-driven marketing. And so if you think about the mission of breaking down industry silos and driving decisive and meaningful action across sort of the healthcare ecosystem, that's a lofty mission that happens to be the mission of Purple Lab. And so before I bring Ted back in with a question, I just want to give everyone a little bit of a 411 and what they really are all about, because they are making that mission a reality by way of this really sophisticated platform called Health Nexus that they created. It's a no-code analytics platform, as they call it, that's powered by a huge database of claims that contains all kinds of transactions dating back to 2012. What were you doing in 2012? Their sources include private health insurance companies, Medicare and Medicaid patient data, and they regularly update this on a daily, weekly, and monthly basis. And they currently have more than 5.5 billion, with a capital B, billion annual claims data from hundreds of diverse sources, including 2.2 thousand health systems, 5.9 million healthcare providers. And this includes data from over 1.6 million HCOs. It gives them about a 98% coverage across all insurers in the country. So they've gained access to this data through partnerships and data aggregation. They de-identified the data and performed statistical analysis to ensure the data is not re-identifiable. So it's completely in line with HIPAA. They're really creating a new way to discover the different perspectives that go beyond raw claims data to interact with your consumers, interact with your patients by offering longitudinal patient data that is actionable in a matter of minutes. You could check them out more at purplelab.com. But Ted, that sets you up because I want to hear about how the most sophisticated hospitals are leveraging that data to enhance their marketing activities, and how should listeners be thinking about precision marketing?
Yeah. So in 2012, I was living as a school teacher in Guizhou, China. So the ICD coding for my GERD episode after I ate the wrong bowl of noodles would not have been captured in our databases. We're US only at this time, sadly. But yeah, talking about what we're trying to stitch together here today. Really appreciate the different people on the call, because I think talking about health equities as being one of access to care in terms of urbanicity and the geographic distance to care facilities is a huge element of those social determinants that drive let's say underutilization of preventative care, and a huge uplift in the ED usage, which the RVUs may be higher, but Lord knows it doesn't resolve to better overall health outcomes for the population in question. So when we talk about utilizing trends in data, a big part of what we understand to be the challenges of leveraging data at scale today is the number of skilled people who understand the complexity of medical data and the interaction of it for very specific use cases. So what we've tried to do is to stitch together in various ways forms of mapping, the coding which captures diagnoses, principally from your ICDs, but also your DRGs, into larger level structures that, people from across an organization can use to analyze and understand the trends in what's occurring in their system and their geography. So, from working with pharmacy, medical, and institutional claims, as an ACO, you want to be able to work with what's happening in the ambulatory center and tie that activity and hopefully those patterns of patient movement into the hospital center as a patient matriculates through a care journey. And that's a huge part of what we do. The social determinants angle that I touched on briefly before, I think we can acknowledge on this call that the largest social determinant in the country still appears from most of the measures that we've looked at to be race, although income and geography and access are huge contributors to that as well. By folding that data in and pre-analyzing it, we can very rapidly move to identify which segments of the population are facing the sharpest market access challenges, and use that to inform, knock-on marketing messaging. To, I think, Tim's point, it's doesn't have to be just about, use these services, but education and driving awareness of the need for that as a first step to really engaging with these programs, some of which operate at no cost, because, the point is to get preventative care in there. I go back to my Ben Franklin, a pinch of prevention is worth a pound of cure, in order to really make the most efficient healthcare system that maintains relationships with the largest number of people, not those who are purely seeking acute care and unfortunately likely to experience similar episodes if undertreatment continues. So, we tie that together, the social determinants data and the clinical data, with understanding, again, pre-patient journey, how to message to those populations digitally, because there are massive variations in consumer preferences with where they like to, consume content, engage, consider what, healthcare might be necessary for them. Like I think a massive divide in the country is there are, people who are heavy Instagram users, and then there are other populations, specifically of different demographic groups that use things like WeChat or other, social messaging applications. And being able to parse that out so that you can actually equitably wait for your engagement across all of the different groups that are, in need of care for one kind or another, is a extremely valuable component of, a marketer's mix.
Ted, any thoughts on using price transparency data that's publicly available in an organization's strategy to grow patient population?
Yeah, so I can't believe I left one out, but payer and formulary status is a huge part of the challenges here, right? So being able to look at utilization, at an aggregate level at the point of, say, a provider, a single point of care facility, or a larger integrated delivery network, gives you a great understanding of how, shifts in policy are going to impact that population. So let's go up, to a nice, comfortable 10,000 feet where everyone feels fine and say, let's think about the shifts that the IRA is going to have in terms of access to care to many of those underserved populations that we've been talking about on the call today, where you should expect to see a pretty substantial increase in the affordability of a broad basket of medications in the fairly near future. Looking at the payer data, I would say one of the things that we would look to understand is, across the set of different healthcare facilities and geographies in the country, where do you see, commercial plans predominate, which are most likely going to, experience some pretty drastic changes in formulary structure, and hopefully how the PBMs are able to facilitate, shall we say, providing medication for a variety of conditions.
Like that. Okay, you're like teaching a course here. If you guys want to introduce to Ted or someone on his team just to ask more questions about this, because I think this is like next level stuff that you should be at least tapping into a little bit. If you want to be introduced to him by me or someone on his team, let me know. I'll make a personal introduction. Sherry, why don't we throw a poll in there? So anyone that wants to be introduced to Ted and his team, I'll just make a one-on-one. You guys can ask questions. You don't need to be sold. We're a community. I'll try to do the best thing here just to get more into this topic. I do want to come back to, it's really tight on time right now. But before we do, and this sort of is in line with a question from the audience member, I want to go back to the convergence sort of our themes: patient centricity, data-driven marketing, and equitable access. And there's a program that in the prep calls that we had that really captured my attention. It's a topic we've covered on this show a number of times. I want to continue to talk about it, around engaging and enabling women with potentially high-risk pregnancies. And so, Molly, could you talk a little bit about what Strong Starts is? It's a super cool program, and maybe just quickly outline the core components. I know we don't have a lot of time here, and I want to get back to Abraham. But tell us a little bit about Strong Starts and what you're doing for pregnancy.
Absolutely. So in Appalachia and surely in other parts of the country, neonatal abstinence syndrome continues to be a significant concern, an area where health systems can really support new and expectant mothers. Of course, those are babies that are born with an addiction of some kind. In our area in Southern Appalachia, babies are born at a rate of 2.5 times higher percentage rates with NAS than any other part of the country. So it's a significant issue for us. Not only are we adding on to our neonatal intensive care unit and building a larger NICU, we really had to take it a step further. And again, through our research to understand our market, to understand what women's health needs were in our area, through our insights research and through conversations we've really been having with our OBs, was how can we support these moms before they deliver the baby with NAS? And so we built a program. It's kind of twofold. Strong Starts is a program where we're surveying moms who are seeking care in an OB office. And then we built a program that we call Strong Futures, which is a in-house kind of a residential treatment facility for new and expectant mothers that are pregnant at the time, that are expecting babies who may end up being born drug dependent or alcohol dependent themselves. And so this is a residential treatment facility where these moms are living with us, living in our care. They're receiving behavioral health services. They're receiving counseling of all different sorts, nutrition services, et cetera. If they have kids already, those kids live there with them. It's really an incredible program. And since we started the program about 3 years ago, 100% of the moms who have completed the program and delivered their babies have delivered their babies without NAS. So
Wow.
it's really remarkable. We're really proud of that, and happy to share more in other contexts if anyone has questions. It's something that really could be duplicated in a lot of other areas.
Oh, I love that. That's why we do the show. I want to back to Oath, bring back Abraham in. I'm going to ask you maybe to put your MD to the side and bring your MBA and MPH into play here. And if I was going to put you in another market at another hospital system, don't tell Baystate, but I'm hiring you away, another
We're
hospital,
live. We're live.
and you're going to start the Oath program somewhere else. How would you resource it? How would you go about kind of building it? Let people kind of figure that out right now. Let's do that.
Perfect. So to have a program that has a clear direction, like access to health, you need the strategic allocation of finance and HR, and the emphasis that we need the right team in the right place. If I had to do something like this is going to be major investment. It's going to bring, again, the data from Ted and the team. It's going to bring that integration to the community, what Tim and Molly have been sharing, and add that layer of how that strategy, the delivery would look like. The partnership between the policymakers on the state and the feds, and I love the question about the price transparency. We can write a book about this and bring the quality while we're implementing. The questions are right on. We need to make sure that we have a robust infrastructure, especially for a model like Oath, like access in the middle of our mission, where the patient and the community at large would have that patient-centric approach to delivery. And then bring it back to the finance. This is a system that we know that it works. It works when we control the cost. It works when our patients are healthy. Our policymaker would give us pat on the shoulder through the incentives where the value-based care will kick in. This is the alignment that we all will look at, but we need to commit to it, Eric. This is the commitment to deliver high value care to our patient.
I want to summarize some of that. So you said finance and HR need to be part of it. You need to have an emphasis on putting together the right team at the right time in the right place. You mentioned major investment. I'm going to come back to that in a second because we need to clear it up. You needed to take data and marketing, sort of the TED class, combine it with connection with the community, the Molly and Tim class. You also mentioned policymakers, state and federal level. Is that a requirement? Can you do it without the feds getting involved, or do you have to have the federal government involved?
You do not need the feds involvement. You need to align the incentives that we get to treat the patients.
Perfect. And that's my next question. So that patient-centric approach to delivery, bring it back to the finance, you called it, controlling the costs, keep the patient healthier, but also gain the financial rewards from being an ACO is what I heard you say. And that leads me back to my major investment. So what's the model there? If you don't have specific numbers, I get it, but like you're going to gain some money from being an ACO and hitting those rewards is what I'm insinuating from your answer. And then what's the major investment roughly? Is there any ballpark that we could give our audience?
I do not have a number. The saving, which the incentives, the 5%, the 9%, the MIPS and the EPS, are the merit-based incentives versus the alternative payment system, the model for how the MACRA would give incentives. I generally think as nonprofit, and I want to spend my career not for profit, is to bring it back to build the team and the integration of the system and the interoperability. So you're taking your incentives and put it back where it matters the most to bring the system all together.
Got it. Love that. All right. I know there's a few questions, folks, we didn't get to. We ran a little bit behind here. These answers were great. I really appreciate all of you and your preparation, your participation today. For all of you watching and listening, I just want to say thank you for letting us fit into your incredibly busy calendar. We do not take the time you spend with us for granted. We hope you use the bright spots shared today to inspire your thinking and just enhance your company's current approach to improving healthcare for all of us. Join us for our next episode. It's live May 9th. Unbelievable panel you see in front of there if you're watching live. So just definitely, we could pre-register you there if you want before you log off. Friendly reminder to subscribe, rate, leave a comment. This really helps us grow. We produce the show for you. Thank you, everyone. Again, this is your Bright Spots in Healthcare podcast. Take care, everyone.